Well, good afternoon, everybody, or I should say good morning. It's Wednesday morning here in Dallas, and it's a nice day, but I am going to stay inside. So I just wanted to say a couple things to sort of bridge us from our topic last week, the module on end of life and the three pillars, and some of the more specific issues we'll be talking about this week, which is physician-assisted suicide / medical assistance in dying, and also artificial nutrition and hydration. So I guess what I'd like to do is to highlight some of the concepts that I think are important here, and I'd also like to link that to what you wrote in your papers, your excellent papers, which are graded, by the way, now and ready for you to take a look at as you write your next paper. So many of you in your papers, in fact, I would say everybody in the class, all 13 of you to some degree, highlighted the fact that for most people and for you, that the way that you make moral decisions is a mixture of different methodologies. In other words, it's not that any of you are you're just a consequentialist, you're just a virtue ethicist. But you all sort of talked about how sort of methodological guidance in making moral decisions for most people is mixed, and I think that's very true and it's very appropriate. And even if people don't admit it, I think it's true. It would be irresponsible for a person to only be concerned about their own personal moral formation and not, say, be concerned about outcomes for others, as I've mentioned in the past. So I thought that was a very good, honest part of your papers, all 13 of the papers. So in highlighting that now, we come to take a look at end-of-life issues, and you can certainly see how, in those cases, moral decision-making kind of has to be mixed, right? Because on the one hand, you'll see, and this is true in Kelly's account in the text of how his mind changed about medical assistance in dying or physician-assisted suicide, that you have to take into account a number of different factors, right? You have to be concerned with your own moral formation as a person. You have to sort of be concerned about not being a person who takes life lightly or who, at the worst, who kills, but even not being a person who treats life casually. And you want to take that into account, but you also have to think about outcomes for others. So one of the things that I mentioned earlier in one of last week's videos was a sort of plot thread in The Pit that's extended over several episodes that my wife and I have been watching. And in that plot thread, there's an elderly man who's suffered a heart attack or a stroke, I can't remember which, at a nursing home, been brought into the emergency room. His son and daughter are there, and they're trying to decide whether or not to keep him alive on a ventilator. And keeping him alive on a ventilator would mean that he would spend, a few weeks, most likely, in significant discomfort because of having a tube down his throat, or that his life would end within the next few hours, but without the discomfort, right? They ultimately decide to take him off the ventilator. And I think from a medical standpoint, ethical standpoint, that looks like a good decision in that particular case. But you can see there that the son and daughter, and what I like about that, the way they do it in that episode, and I certainly commend the series, The Pit, to you. If they, they're talking about sort of, they want to value their father's life. They want to keep him alive. They love him. They want him to be around. They don't want to be the sorts of people who are going to, treat his life casually or prematurely end his life. But on the other hand, they are also trying to think about what his quality of life is going to look like, right? They're going to think about outcomes, right? What does the end of his life look like in this or that case? And the doctor is very clear in explaining that to them. So that's, I think, what we have to think about here is how these different, one of the things we have to think about is how these different modes of moral decision-making are used in sort of balance with each other. That's one thing. The other thing I wanted to highlight is the importance of intention in all that we're talking about here. So, some of the cases that you talked about and sort of posited for principle of double effect are cases that were end of life, and those were very good illustrative cases. Because at the end of the day, a lot can be sort of discerned from thinking about whether the person who's doing the action that we're talking about, whether it's administering medication or stopping the administration of medication or whatever, what is their intention, right? Is and by that I mean the sort of direct, what we call the proximate intention of the act, right? Are we trying to end your life in order to end your suffering, or are we trying to reduce your suffering? And a consequence of that might be that your life would end earlier, right? That's one thing the principle double effect reveals to us, is that if I think I mentioned in the PowerPoint, if what would appear on the death certificate would be important when you're thinking about this, right? If you take someone off a ventilator, who has had COVID, say, and is unable to breathe on their own. You take them off the ventilator, the death certificate's going to say that they died of COVID or COVID-related syndrome. It will not say they died of lack of ventilator, right? On the other hand, if you administer a lethal dose of morphine and Versed to a person who is terminally ill in order to end their life specifically, right, to stop their suffering by ending their life, then what's going to go on the birth certificate is not stopping suffering. It's going to be lethal dose of morphine and Versed. And I think that that's one way the church the Catholic Church uses to sort of understand the difference between physician-assisted suicide, medical assistance in dying, euthanasia, actions that directly, intentionally take the life of the patient, and actions that are about withdrawing or withholding treatment that may mean the patient dies more quickly, right? Does this seem like a a really fine distinction, like I'm making these sort of fine moralistic distinctions? I don't think that's the case. I think it's an important distinction, because if you stick to, in my opinion, if you stick to only the sorts of actions that would mean withdrawing or withholding care, and you stay away from actions that you know would directly lead to the death of a patient, then I think you're going to stay away from some pretty problematic moral areas, right? The one exception to that, I think, that we talked about a little bit is palliative sedation, where a person who is terminally ill, very close to death, is sedated so heavily that it might possibly accelerate their death, right? And I've seen this. I believe it was probably the case with my mother, that she probably died a little bit more quickly because she was taking morphine. In that case, she was very close to death, and we were talking about the difference of days or hours even in terms of when she was going to die. But if we get down to the intention, we were not administering morphine with the intention of ending her life more quickly. We were administering it with the intention of keeping her comfortable. So we'll think about that as we move on and talk about some of these difficult issues. And I will look forward to seeing your discussion chats about that. Thanks very much.